Hello and welcome to the AABIP podcast. On this podcast, we go one step beyond publications and guidelines to speak directly with leading experts in interventional pulmonology. This podcast will address not only fundamental topics in exciting publications, but also unconventional topics for which the evidence base isn't that robust. The views expressed on this podcast are those of the speaker and not necessarily endorsed by the AABIP. This is your host, Udit Chadha, an assistant professor at the Icahn School of Medicine at Mount Sinai. And with that, let's dive into the next episode. There are a few studies that have looked at the role of medical thoracoscopy in patients with empyema. Until recently, all were retrospective. And I apologize if I get some of these pronunciations wrong. The first one was by Brachi in Chest 2005. It was a retrospective case series from 1989 to 2003 from 3 centers in Europe, involving 127 patients with sonographically multiloculated empyema. 1/3 had failed chest tube drainage alone. 49% needed post-medical thoracoscopy fibrinolytic therapy. 1.5% needed further chest tube. 1.5% needed a second medical thoracoscopy, and 6% needed a pleurectomy by a thoracic surgeon. Ravaglia in Respiration 2012 published a retrospective series from 2005 to 2011, including 41 patients from a single center in Italy. Now, in this study, medical thoracoscopy was considered successful, radiologically defined criteria, without further intervention being needed in 85.4%. Now, importantly here, if you look at those who had a free-flowing effusion, that is 9 patients, all 9 achieved success. From those who had a multiloculated empyema, 22 of the 24 patients had success, and only 4 of the 8, 50% with an organizing effusion, that is stage 3 empyema, had success. But 61% also received fibrinolytics in the study. Hardavella in JOBIP 2017 had a retrospective series of 84 patients in which 89% was stage 2 empyema. Patients with stage 3 were directly referred for VATS, and they had an 80% success rate. That is defined as the need for a second procedure, without the need for a second procedure. Now, 4.8% needed a second medical thoracoscopy, while 15.5% needed VATS. Now, other studies have also been published, including a 16-patient study by Solar in 1997, a 29-patient study in 2014, and there's a subgroup analysis from a study in the Annals of Thoracic Surgery 2010 by thoracic surgeons. Now, all studies look at the rate of avoiding VATS, which is basically around 80 to 90%. However, the same success rate has been achieved with intrapleural enzyme therapy or intrapleural therapy with TPE and DNase, as shown in the MIST-2 trial, as well as several other studies, which have clearly established the utility of these 2 agents in avoiding surgical intervention, whether they be administered synchronously or sequentially or once daily or twice daily as rescue therapy or upfront initial therapy or even extended use. So intrapleural enzyme therapy, though, recently was first compared with medical thoracoscopy in a small randomized controlled trial, which was authored by our 2 guests tonight. Dr. Fayez Kheir is an assistant professor of medicine at the Beth Israel Deaconess Medical Center in Boston, and Dr. Hiren Mehta is an associate professor of medicine and the program director for interventional pulmonology at the University of Florida. Fayez and Hiren, thank you so much for joining me on the podcast today.
Thank you for having us.
So, Fayez, I'll start with you. Do you have any relevant conflicts of interest to disclose?
No, I don't.
And Hiren?
No, not related to the study.
Perfect. Thank you so much. All right, Fayez, would you mind briefly telling us about this recent randomized trial that you conducted looking at TPA-DNase versus medical thoracoscopy?
Yeah. As you said in the introduction, there's a lack of comparative data between 2 acceptable modalities for treatment of complicated pleural infection and or empyema, which is medical thoracoscopy, which can be regarded as mechanical adheolysis, or intrapleural fibrinolytic therapy, which can be regarded as chemical adheolysis. So in this study, we did a randomized multi-center controlled trial comparing the two modalities, with a primary outcome will be the length of hospital stay following the intervention, and secondary outcome, which was the total length of hospital stay, treatment failure, 30-day mortality, and adverse event. And the conclusion was in highly selected patients with a complicated pleural infection and empyema, medical thoracoscopy has decreased the length of hospital stay following the intervention clinically and statistically as compared to intrapleural fibrinolytic therapy. There was no difference in treatment failure or adverse event between the two modalities. There was a decrease overall length of hospital stay, which is probably clinically relevant by 2.5 days without being statistically significant.
Okay, thank you so much. So you said that the length of stay was shorter. Just out of curiosity, Fayez, why did you all choose length of stay as the primary outcome when the two interventions differ in duration?
Yes, sure. So let's dissect more into the question. First, the length of stay comparing intrapleural fibrinolytic therapy or VATS, it's not a new idea. This has been compared before in the pediatric literature in 4 randomized previous trials. One of them was back in 2006, then 2009, 2011, and 2014, where they compared TPA, urokinase, streptokinase versus early VATS. Mm-hmm. And they chose a primary outcome as the length of a hospital stay from the day of intervention. This is number one. Number two, the length of hospital stay following intervention will always depend on the clinical improvement of patients. So if patients did not clinically improve, obviously, whatever intervention you did, it will unfortunately prolong their hospital stay. The third thing is, if you look at the literature you presented before about the medical thoracoscopy, you can say that the hospital length of stay following interventions in the first 3 trials you mentioned was between 7 to 8 days. Mm-hmm. In the IPFT data, I'm going to quote 2 studies. One is the ADAPT trial, where the median hospital stay was 7 days following the intervention, the first dose. And our previous study back in 2016, where we had 75 patients treated with TPA-DNAs for pleural infection, mm-hmm. and our hospital stay following intervention is 7 days. Mm-hmm. The last thing is, if you quote the data, if you exclude the patient, the MIS2 trial, which had a protocol of 3 days of TPA-DNAs, mm-hmm. we can see in the literature that the median dose of TPA-DNAs needed to have a good treatment success is 2 to 3 days. Mm-hmm. While to conclude...
2 to 3 doses sometime, right?
Yes, exactly. Mm-hmm. So to conclude, while yes, there might be some bias toward medical thoracoscopy, but for the previously mentioned reasons, we did not think that the outcome, the primary outcome, it's going to be biased toward medical thoracoscopy versus TPA-DNAs.
Got it. Thank you so much, Fayez. That's very clear.
So, and Uday, to chime in,
yes, Hiren.
I think one of the reasons why we chose hospital length of stay is because, there are several outcomes that you can choose. And we know that from the MIS2 trial that intrapleural fibrinolytics are actually very successful. So if you were to choose treatment success as a primary outcome, we know that intrapleural TPA-DNAs from MIS2 trial is actually very good from a treatment success standpoint. Mm-hmm. However, one of the biggest criticism of MIS2 trial was a median hospital length of stay, which was, mm-hmm. as you know, between 10 to 14 days.
Yes.
And so we wanted to show something which is better than what the MIS2 combination is. And the way we could show it is by showing something which would significantly decrease the length of stay as compared to the MIS2 cohort. Okay. And so that was one of the thoughts behind choosing length of stay as a primary outcome as well.
Mm-hmm. Perfect. Thank you so much. So Hiren, if you can just tell us, so the use of medical thoracoscopy for empyema is not something that is widely practiced. There are select centers with expertise in this, who are indulging in this practice. So let me just ask you generally, how does your IP practice work? Is everyone with an empyema in your hospital get an IP consult, or some get thoracic, some get IP? How does that work?
No, so in our practice, to answer your question specifically as to how the workflow works when the patients with empyema or complicated paraneumonic effusions get admitted, and I realize that all practices are different. In our practice, pulmonary gets consulted on all these patients, and IP automatically gets involved with all these patients. So a vast majority of these patients, the workflow is they get admitted to some form of medicine service, and then pulmonary and interventional pulmonary get consulted on this.
And does thoracic surgery get consulted by interventional pulmonary if
yes,
need be?
That is correct. So thoracic surgery, majority of the times, comes in on the back end. And when we realize that our treatment that we are offering is not working, or we realize that likelihood of treatment success is small with the minimally invasive intervention, is when we consult thoracic surgery.
Okay, so you are not using a VAT-first approach for empyema.
Okay. That is correct.
And Hiren, and Fayez, is it the same at your center?
Yes, at Beth Israel, as probably you know, that we are under thoracic surgery. And every patient with a pleural infection, we get consulted. And as Hiren said, the thoracic surgery will be as a backup if any treatment modality we offer failed.
Perfect. And if I may just clarify, at both your centers, are you all using intrapleural therapy with TPA DNAs as initial therapy? That means, you see a patient with empyema, irrespective of the sonographic findings, you start TPA DNAs, or are you using a rescue therapy? Like, you put a chest tube, you do your saline flushes if it's a small bore, and you reassess, after a few hours or a day, sonographically and clinically. And if there is no improvement, then you do it.
Yeah. So in our practice, we do it upfront. So any patient, so not all, as you know, not all paraneumonic effusions, but complicated paraneumonic effusions and empyema. Certainly, you have to wait for the results and everything to come back to prove that it's a complicated paraneumonic effusion.
Of course.
But we don't wait for pigtail to succeed. We just upfront do intrapleural fibrinolytics and DNAs.
Perfect. And Fayez, is it the same at your center? Yes. Stage 2, stage 3? Okay.
Yes, we do as initial treatment TPA DNA, especially in ultrasound proven loculations and echogenicity.
Yes. Okay, so like MIS2, you all are doing initial therapy.
Yes.
Okay, so then Fayez, if you may answer this, then what is the role of a medical thoracoscopy? Where does that fit in?
So for medical thoracoscopy, let me just clarify your question. Are you talking about when do we think about medical thoracoscopy as initially compared to IPFT?
Correct. In your algorithm of treatment, when do you consider medical thoracoscopy?
Yes. So first and foremost, for in order to do a medical thoracoscopy, it's operator dependent. So which means that the operator has to be more comfortable dealing with a complicated pleural space, because this differs completely from going to do a pleurodesis or a pleural biopsy, or with a patient of undiagnosed exudative pleural effusion. So this is number one. Number two, as we mentioned, we always, if we prefer to do medical thoracoscopy, we do it early in the disease course rather than late in the disease course. And number three is it depends, as we said before, on the ultrasound. In patients who has loculation, sometimes we elect to do a medical thoracoscopy as compared to IPFT, and especially in certain situations. For example, if a patient is on anticoagulation and his anticoagulation cannot be interrupted for a very long duration, we sometimes offer patients medical thoracoscopy so we can clean up the space and then they can go back on their anticoagulation rather than having to interrupt it or stop it for some time to see if the TPA DNA is going to work or not.
And just to clarify, when you say you use medical thoracoscopy early, I presume you mean that you're giving a couple of doses of intrapleural fibrinolytic therapy, at least, and seeing the response to that, which is clinical and radiographic, and then deciding whether or not there is improvement.
Actually, yes or no, and no. So yes, sometimes we give TPA DNAs and then we reassess if this is going to help or not. But however, sometimes we just initially decide to take patients to pleuroscopy, medical thoracoscopy or pleuroscopy for pleural infection in patients who has complicated paraneumonic effusion and debridement, like loculations on the ultrasound. The only time that we do not consider a medical thoracoscopy because we know it might have an increased risk of failure is in patients who has an high echogenicity on the ultrasound or a fibrothorax or a very thickened pleura. We know upfront that medical thoracoscopy has a success rate of less than 50%. So usually we start TPADNAs and then we refer them to thoracic surgery afterwards.
Okay, and hold on to that thought, Fayez. We'll come back to that. So, Hiren, when you're doing medical thoracoscopy at University of Florida, what is the scope of intervention? What all are you doing? I mean, you're doing adhesiolysis, but are you decorticating as well? Can you just tell us, are you putting targeted chest tubes? What all are you doing?
Yeah. So just to get you up to speed on what we do at University of Florida is we do a single port medical thoracoscopy, and we do rigid thoracoscopies on all these patients. And we do all of them under conscious sedation. And so basically, just to get you up to just to systematically go over what we do, our approach is once we get the port in, certainly we try to suction as much of the complicated infected fluid as we can and try to clean out the space. Once the space is cleaned out, then we start doing the adhesion lysis. And we try to do as much as possible the blunt adhesion lysis. And Fayez, correct me if I'm wrong and if your practice is different, but we tend not to use scalpels or forceps or scissors to cut the adhesions, but we try to bluntly dissect the adhesions as much as possible and try to make the space as uniform as we can. And make sure that our thoracoscope has a good maneuverability around the entire pleural space.
Now, are you using the scope? Are you using a peanut? What are you using to bluntly dissect?
We use the scope. We use sometimes the forceps, but not for cutting purposes, but just for bluntly dissecting purposes. That is correct, yes. And once we achieve as much adhesion lysis as possible, then we do thoracoscopic guided chest tube placement into the largest locule or the ones that we think need to be drained most, and then come out and close the case.
So you're not decorticating?
No, we are not decorticating. That is correct.
Fayez, is it the same at your center?
I totally agree with Hiren. The goal is not to dissect or just cut the adhesions. The goal is just to free the lung from all the loculations and try to make the lung free again in order to the lung to inflate again. What I will add also, we do some biopsies for microbiology. I don't know if Hiren, you do the same thing.
Yes, that is correct.
Yes, we do biopsies for microbiology because we know there's probably hopefully increased targeted therapy with antibiotics if we are able to find out exactly what the culture looks like. We also use something called an endokittner device. It's it's a device where you can just remove the adhesions very gently and not cutting them. And the goal is not to remove all the debridement because we know that once your pleural space is free, antibiotics and chest tube will eventually get rid of all the debris.
Perfect. Thank you so much, guys. So, Hiren, this comes back to a very general, medical versus surgical approach in all likelihood. But what do you think are the advantages of doing medical thoracoscopy compared to a VATS?
So, I think that's a very good question. And you probably know, and I think it's probably the patient population is probably the same around most of us, is that most of our patients who have empyema, complicated parapneumonic effusions, have a lot of underlying pulmonary conditions. Their general health is actually not great. And so a vast majority of them for VATS should be able to tolerate a single lung ventilation, which a lot of our patients may not. The advantage of medical thoracoscopy is, one, you do not, in our cases, we do it under conscious sedation, so you do not need general anesthesia. Second is that there is no necessity for a single lung ventilation. We typically do not intubate them with a double lumen ET tube and collapse one lung. So they can get away without a single lung ventilation. So it's much better tolerated. Certainly downstream, because it's a single port thoracoscopy, the pain is better. And overall, if we can show that with a procedure which can be done without having patient to be under general anesthesia and with a single port with less pain and have good outcomes, I think those are some of the major advantages of medical thoracoscopy.
And just for the listeners, I'm sure this approach is taken up by these experts because it's a safe approach, right? They probably aren't seeing many complications with this. I'm not that I say that I see it, but it's a safe approach. I think that's what justifies it, at least with the available expertise.
Absolutely. And as you can see from our study, there were minimal to no complications with medical thoracoscopy.
Absolutely. So Fayez, let's look at the other side of the coin, So let's talk about the limitations of such an approach. Now, you and I know very well that, stage 2 empyema, the fibropurulent stage, possibly treated well with intrapleural enzyme therapy or fibrinolytics and DNAs, and medical thoracoscopy possibly has a role there. But, once you get into stage 3, which has an organizing pleural rind, other than decorticating, there's really not going to be much options there. So clinically, this the transition zone between stage 2, stage 3 is very gray. And it's very difficult to, look at the CT scan sometimes and the ultrasound sometimes and predict that this space will not have a pleural rind, though sometimes it's obviously clear. So how often are you having a failed medical thoracoscopy, in the sense that you enter the space and you cannot achieve success, or it needs, a thoracic surgeon on board to do something more?
Yeah. So first, if on the ultrasound we have a highly echogenic appearance or a fibrothorax, we definitely consult thoracic surgery and probably do TPA-DNAs 1 to 2 doses, which we know they are going to fail, unfortunately. And then we refer them directly to thoracic surgery.
So can you expand that a little bit? What do you mean by echogenic effusion, and what sonographic features of fibrothorax are you looking at?
Yeah, if you look, I don't know if you had the chance to look at the study. We had a figure where we showed that under ultrasound guidance, you can see that the effusion is really highly echogenic, which means you are at the stage of really organizing empyema. And we know from that the success, even with a TPA-DNAs or medical thoracoscopy, is almost probably very minimal, or at least less than 50% of the chance. Okay. And this is number one. Number two, if we inserted a chest tube, we drained the fluids and the lung did not expand, it means that there is a thick pleural rind, and the success of medical thoracoscopy and or TPA-DNAs is very low. Okay. And the third thing is, if a patient has hemodynamically unstable due to an ongoing sepsis or chronic pleural empyema, we know that TPA-DNAs or chest tube or thoracoscopy will not work. These are the cases usually we like to refer directly to thoracic surgery early in the disease.
Perfect. Thank you so much, Fayez. So Hiren, what about you? When do you consider a VATS by a thoracic surgeon?
So like I mentioned, majority of the times, unless it's very obvious upfront that, this patient is going to have a thick pleural rind and this patient has a chronic pleural empyema or has a lung entrapment, and your medical thoracoscope is not going to work. Like you said, majority of the times when these patients come in, it's hard to know. And it's hard to know whether this patient is really going to have success or is not going to work. And so most of the times we don't do VATS up front. We either pursue medical thoracoscopy or intrapleural fibrinolytics, and at that point, once you clear out most of the fluid, is when you start realizing that this patient's probably not going to have a good outcome with minimally invasive approaches and will probably need VATS. And so, unless things are very obvious upfront, I would say that majority of the times the VATS is a backup.
Got it. Perfect.
I want to add one more thing. I agree with Hiren. Just want to add one more thing just for the listeners. Medical thoracoscopy should be regarded as complementary to VATS, and it does not preclude patient eventually from going to VATS, because medical thoracoscopy can be regarded as mechanical debridement, okay? So it's especially, for example, if you have TPA-DNAs, which is a chemical adheolysis, you will eventually, if they are not responding, you send patients to VATS. Probably medical thoracoscopy should be regarded as the same thing.
Perfect. Thank you so much, guys. This has been fantastic. I think I've learned a lot from you guys, and I'm sure our listeners will love your pearls of wisdom. Do you all want to put in any closing comments? Something about the future, something you'd like to be studied in more detail? Hiren, you want to go first?
Yeah, I mean, I think as Fayez and you mentioned, this is a great first step in randomizing patients and studying them head to head. As you all know, that there is a lot of questions which are unanswered in the field of pleural space infections, including and as we have seen different approaches, including upfront fibrinolytics versus rescue fibrinolytics in the pleural space, once daily versus twice daily fibrinolytics, how often to do it, how many total doses to do, early thoracoscopy versus early fibrinolytic therapies. And so there are a lot of unanswered questions. And I think as a community who take care of these patients all the time, I would like to see more and more studies done along the same lines, high quality studies, randomized studies answering each one of these questions.
Perfect. Thank you so much, Hiren. And what about you, Faz?
Yeah, I agree with her, and I think there's too many unanswered questions and uncertainties in pleural diseases as general and pleural infection in particular. For example, using of steroids in pleural infection, using TPA DNAs, we know that the dosages were chosen empirically. Is there any other medication or different dosages that can help? Medical thoracoscopy, early VAS or early medical thoracoscopy. So there remain so many unanswered questions, and the hope that hopefully in the future with all randomized trials, these questions should be addressed and answered.
Perfect. Thank you so much, guys. This has been very, very enjoyable for me to host, and I'm sure our listeners will enjoy this as well. Thank you so much for your time.
Thanks for having us.
With that, we conclude an exciting episode here on the AABIP podcast. I hope you guys enjoyed listening to it as much as I enjoyed hosting it. Do also check out our website, theippodcast.com, and please do provide us with feedback and suggestions on what topic and which expert you want to hear next. Until next time, take care.